All right, welcome back to another episode of Now I Know. I'm Sam Barry,
And I'm Sud Koushik.
and today we're talking about intraocular lenses, so IOLs. So just jumping right in here, IOLs, when do we use them? What are IOLs?
IOLs, like you just mentioned, intraocular lenses, we are using them after the patient has their natural crystalline lens removed from the eye. So you can do that before the patient develops a cataract, and usually we call that a refractive lens exchange or a clear lens exchange. You can also do that more commonly after they've developed a cataract, and we just call that cataract surgery with an intraocular lens implantation. Um, and a lot of patients, I think, ask us where this lens goes and does it need to be sutured in, or how does it stay in its place, those kind of things. So, Sam, why don't you walk us through that?
I'm always ready. I've got the eye model. I've always got it in my pocket. So
Nice.
again, for the podcast listeners, we appreciate you. We'll talk through it, but also the video part, the YouTube part, super high yield to be able to see it and visualize that. So looking at our eye model, the way we see each other is just like this. So a kind of a cross section. We're looking behind the iris, or behind this, browned part of the eye. The opening in the, center of the iris is called the pupil. So with any lens-based surgery, cataract surgery, refractive lens exchange, we dilate that pupil. So we get a better view back here to where the lens sits. So the lens is held in place, like I think you've talked about before, Sud, but by a structure that's called the capsular bag that's held in place by zonules, kind of like trampoline springs. So these trampoline springs hold the lens in place. So looking again, kind of for our visual learners out there, our lens is nice and clear when we're younger. And then the first sign of a cataract developing, or the first sign of what we might call dysfunctional lens syndrome, is needing reading glasses. So somebody who's never needed glasses before in their life, in our 40s or 50s, is going to start needing reading glasses. And that's because that lens inside of our eye can no longer accommodate. And accommodate just means changing shape so that it can increase power, and focus up close. So like you were talking about, Sud, options with taking this clear lens out and then putting a new lens in. So this lens kind of has a central optic, and then most of our lenses have two arms that come off, and we call those haptics. And so they sit right behind the iris, and you can see, looking in the eye, from an undilated standpoint, you can't tell the difference between that clear lens that was there before and now our intraocular lens, or IOL. So it sits just where it did before with the crystalline lens. And somebody who's had surgery versus not, you really can't tell a difference just by looking at them.
Yeah, I think that was a great summary and overview of where that lens sits and how it's positioned. For our listeners, basically, is this type of lens, this intraocular lens that you alluded to, is there just one type? Are there multiple types? How do we determine as ophthalmologists what type of intraocular lens to put into a patient's eye?
Yep. So that's the question. That's the real
That's
question.
the big question.
This lens, even though it looks like just one clear piece of acrylic or silicone, there's actually many different varieties. And I don't know how you do it. I'd love to hear how you talk to patients about it. But I say the lens choices that we have are similar to what you might see for glasses. So glasses can be distance only, they can be reading only, or they can be bifocals. Or progressive is a name for a no-line bifocal. So they can have those choices. And we can do that with glasses, and people understand that conceptually. I think I understand that conceptually. As an eye surgeon, all this stuff comes kind of second nature to us now. But ask me 10 years ago, and I wouldn't know the difference between what a progressive lens is and what just glasses are, right? So progressive just means no line bifocal. And we can do that with glasses. We can do that with IOLs, or intraocular lenses too. So that's kind of how I go about starting the discussion, is to saying, think about glasses and think about what those can do for us. And then let's talk about how we can do that with IOLs.
Yeah, I think that's fantastic, is basically taking that reference point that I think a lot of people are already familiar with, their glasses, and then using that to help get them a starting point for what intraocular lenses can do for them. I like that. I kind of use a similar analogy with patients as well. And then usually after that discussion point, we kind of jump into what their goals are. And I think that really helps drive us as surgeons for choosing the right intraocular lens for the right patient, making sure it's a good marriage of sorts between patient expectations and then also what the technology of the lens can actually deliver, and making sure those two are aligned. Because I think you and I both know there are a lot of great, fantastic intraocular lenses that just might not work well for a certain patient. Um, and just it's not a one size fits all type approach.
That's exactly right. I couldn't say it any better. I mean, we always want to do exactly what best suits, what someone's looking for, while also understanding we still have, although we have amazing technology, there's still some technological limitation to what we can do. And the way that I say that, somewhat in a tongue-in-cheek way, is to say, we can get oftentimes 20/20 vision, but we can't get the vision that you had when you're 20 years old. So the vision when you're 20 years old is your natural crystalline lens, like we talked about, that can change shape and can focus up close and can focus at distance. And that's the best quality of vision we're ever going to have, at least right now. Our goal long term as a community of eye surgeons is to develop lenses and technologies that can emulate that to, either that degree or even, exceed that degree. And in some ways, we kind of have exceeded that degree. Just as a quick aside, somebody who's 20 diopters or 20 units nearsighted, we have lenses that can instantly fix that. So the way that somebody has been living their life, their entire life, with surgery can be so much better than it was ever before in terms of reliance on glasses. Now, what we're trying to really do is push that envelope to somebody who's never worn glasses before and somebody who just needs reading glasses. How do we get them back to the vision they had, 10 or 15 years earlier? And so, we can go more and more down kind of different patient presentations and what expectations are. But like you said, it's our job to think through all the IOLs that we have experience with and that are available, that are FDA approved in the US. And for that number, I'm going to rely on you, Sud. I'll bet you know the number right off the top of your head.
Oh
How many
man,
IOLs are we talking about? Is it like 5 IOLs to choose from? Is it 10? What's the ballpark?
I would say based on what we've gleaned, you could expect over 50 different IOL options within the United States that are FDA approved. And then within those 50, they come in a myriad of different powers for the patient. So really, you put that combination together, and we are talking about a sheer tremendous amount of different IOL options for any given patient.
We're up in the thousands there, right? We're up in the thousands of
Yeah,
choices for IOLs. So
that's right.
you kind
And
of
so it's kind of daunting.
yeah, it is. It is. You touched on this earlier, but you were talking about how each lens kind of is custom for each patient. Can you talk more about how we choose those lenses, how we prioritize kind of what the
Yeah.
patient is looking for? Maybe just going through just a patient that comes in that knows they want lens-based surgery, whether that's cataract surgery or refractive
Mhm.
lens exchange or clear lens
Mhm.
exchange. All those are kind of very similar terms, right? But somebody
Yeah.
comes in, and where does that discussion start? Do you have them, fill out? I know a lot of practices have people fill out, surveys or forms that kind of get a gist of how much they want glasses independence or not, and kind of, can you take
Yeah.
us through what a patient can expect?
Yeah, definitely. So, yeah, our practice too utilizes those forms that you were mentioning where patients can fill out their desired level of spectacle independence. They can even mention certain hobbies that they enjoy doing, and that helps us as surgeons kind of figure out the goals for this patient. Um, After those kind of forms are done, and those also will include for the patient, their past medical history. It'll include previous eye surgeries that they may have had, because we're always looking, has this person already had LASIK? Have they already had PRK? Have they already had SMILE? These kind of things. Or even not from a refractive standpoint, have they had a retinal detachment in the past? And do they have a scleral buckle? So all of these things add nuances to choosing the right IOL for this patient. So we are looking at past medical history pretty extensively, and patients will be kind of filling that out on their form. And then, of course, thorough family history as well, looking for any kind of hereditary conditions that are always sneaking up on us, and things like glaucoma. And so we're looking at all that first, and with that information and a good thorough eye exam, then we can start talking to the patient about exactly what their lens options are. And I would say for the vast majority of patients, especially if we're talking about insurance patients who are coming in with their medical insurance and what they want to have after surgery, they're just looking for, how can I see better? Like in the
Hmm.
most general terms, I'm currently not seeing well. I would like to see better. And I'm okay with wearing glasses even after surgery. I just want my visual quality to be better. I would say
Hmm.
that is a very large proportion of patients. Um, and so I think starting from this patient perspective is just makes it easier before we get into all the more tricky situations. But to give kind of a case example for listeners, you might have a typical patient who comes in. They're, let's say, 70 years old, and they have a no past surgical eye history.
So a
And
very young patient, you're saying, 70 years
a
old,
very
like a young
a
buck. Yeah.
very young patient,
In
a
our
very
patient population, I do tell people that's a very young patient. I mean,
yeah,
I don't know.
exactly.
We do patients in 90 and 100-year-olds sometimes. So yeah,
Definitely, yeah.
yeah.
And
Sorry to interrupt
70
you there,
and
but I had to clarify that's not an old patient. That's a young
no,
patient.
no, that's a young patient, and that's a patient who honestly probably is doing a lot of activities still. There, you'll have patients come in and they'll say, "I just drove from Florida to Missouri,
Hmm.
um, just the other day." So these are people that are very active, living a fulfilling lifestyle, and we want to make
Hmm.
sure that they're able to keep doing that. So, yeah, like this, let's say a 70-year-old patient comes in, they want to see better, they have no previous eye surgery history, and so this patient then will say, "Hey, doc, I'd really like to see better. I feel like the cataract's causing a lot of glare. My visual quality, things are dimmer. I have difficulty driving at night." These are all common things that we hear. And for this patient, I basically kind of break things down very simply. Number one, right off the bat, are you okay with wearing glasses after cataract surgery? And if they say yes, I don't mind. Then from there, we're going into a question of, what is, if you didn't have your glasses with you, how would you like to see? Would you like to see things better at distance, or would you like to see things better at near? And so this is basically choosing a target for the patient. And this is also where our brains start really working with, what type of lens are we going to put in, what power is that lens going to be, and then also educating the patient that the best possible vision even after cataract surgery will come with a pair of glasses, like you mentioned, bifocals or progressive glasses, which will really help them at distance as well as near. So this is just kind of like a generic, very basic patient presentation where it's pretty straightforward with what you're going to do as a surgeon. You're going to remove the cataract. You're going to put in this lens that will help them see either better at distance, which I would say maybe 90% of people come in wanting that good distance vision. And then they wear readers for up close, or they wear bifocals to improve their distance vision and give them better near vision. That would be a pretty typical patient, I would say, for a typical clinic day. What about you, Sam? Any things that you would add to that?
No, I think you hit all the highlights there. I mean, I was trying to think of questions as you went, and you were just knocking them out as I was thinking about them. So I was thinking, like, from a patient perspective, what are the main complaints of cataracts? Like, how would they know they have cataracts? Because they're not painful,
Yeah.
right?
Hmm.
They're, like you said, kind of slowly progressive, and that they typically happen in our 50s plus, typically 60s plus. Um, the age range of 70 is where a lot of people, in their late 60s and 70s start to decide, I'm not seeing as well as I want to, even with the best pair of glasses that my eye doctor can get me. And I especially hear a lot of, I stopped driving at night. And I'm like, oh,
Hmm.
why'd you stop driving at night? And they're like, well, I just didn't feel safe anymore. I couldn't see as well as I needed to. There was glare from oncoming headlights. And that's a real quality of life issue. I mean, when it
Yeah.
gets dark at 4:30 or 4 o'clock in the winter, that's, you can't stop driving at like 3:30 every day. Um,
Yeah.
so pretty significant. And then obviously it runs the whole spectrum. Some patients come in when their vision is just starting to drop off and they're having difficulty, and other patients wait because they're scared about surgery or not sure why they're losing vision, not sure there is a way to correct it, and they'll wait until they can barely see their hand moving in front of their face,
Yeah.
and then have surgery. So I'm sure you've seen that whole spectrum too. Um, But it's good to know as a patient that it's good to just come in and see if it's a reversible or treatable cause of vision loss, right? Because the nice thing is, with how far eye surgery and ophthalmology, optometry, all that has come, is that a lot of things are treatable and reversible. There's very few things remaining that we really have no good issue for, at least slowing and preserving vision, but oftentimes restoring vision that you had before.
Yeah, definitely. I think that's a great point. Is if you are a patient that has been noticing a change to your vision, definitely just please stop in at your local optometrist or ophthalmologist office and just get it checked out, because like Sam said, there are a great many things that we can do, and things that don't take that long, that will tremendously improve your quality of life. So I think that's an excellent point.
Well, let me, for a second, just because you opened up that, good patient presentation of a 70-year-old coming in, typical cataract surgery patient that we're talking about. From their standpoint, like you said, medical insurance really does a good job of covering that, and Medicare, as well as commercial insurances, really cover medically necessary cataract surgery. And so from their standpoint, it's like many other doctor visits where you show up and you take your insurance, you take your past medical history, you start out with one of our technicians, and just setting the table of expectations. It's my opinion that the doctor's visit, should take about, for cataract surgery evaluation, maybe an hour to an hour and a half. That's about what I'd expect as a patient. If it's taking, 4 hours, probably too long. Some people are, very, very thorough, and their offices are busy, and I get that too. But typically, and I'd love to hear what you think too, just an hour to an hour and a half is that range of, you have to come in, we have to check your vision, we check your glasses if you're wearing them. We talk about all your medications you're taking, past medical history. We do a lot of measurements, and we'll get into why we do those measurements, but you're going to probably be on a minimum of 2, 3, 4 machines that are all taking measurements of your eye and letting us know, what lenses might suit you well, what other eye diseases we're screening you for, and just overall giving you kind of a good physical exam of your eye. So from that standpoint, all those tests, all that charting, by the time that you see us, you also need some time for dilation typically. So we have to put drops in, and those drops make the pupils large so that we can look through those pupils and see what the cataracts look like. Because when we do your surgery, you'll also be dilated, and we want to see exactly, what we're kind of planning for. We're doing, kind of a walkthrough of what the surgery would look like from our standpoint, as well as being able to visualize things that we just cannot see if your pupil is dilated. And for me, just real quickly, I'll let you jump right in here, Sud, but I make that analogy of, it's like trying to see into a room if your eyeball is like the room, but we're trying to look through a keyhole, right? But instead, we need to dilate the pupil. We need to open the door. That gives us more room to go in and look around inside the eye, look for things in the peripheral retina, look for anything else that might affect your vision besides just the cataract.
Yeah, I think that's fantastic. That's actually way more eloquent than how I say it. So I'm probably gonna steal that analogy and start using that. But no, I mean, it's so important to have a good dilated eye exam before having surgery. So I think for patients not realizing necessarily the importance of that, but mainly I think focusing on the fact that, okay, this is adding time to my visit, and now I'm also dealing with the fact that my eyes will be dilated the rest of the day. I just want to help kind of underscore that point, that really we're doing it for a safety reason. We want to be comprehensive and thorough, make sure that we address all the reasons why your vision is the way that it is, and assess for any things that could make the surgery, a little more, let's say, out of the ordinary. We want to always detect those things first and foremost. So the dilated eye exam, I think, is an essential part of that preoperative cataract visit. So it's not just a needless waste of time.
Yep, absolutely. So let's say we're about 45 minutes into the visit. So I'm the patient. I've had all the testing done. I've gotten the drops for dilation. Things are getting a little blurrier. Maybe I've moved from a couple of rooms, from the initial room to a testing area, then to another exam room. So I'd say about that time, 45 minutes to an hour is about where you start probably talking with your doctor and having an exam at that point. Maybe some educational material. I know I like to try to show everyone a video that gives them kind of what we're talking about today, gives them ideas about what we can offer with cataract surgery, what lens choices are out there, and gives them kind of all the level playing field where we can go into it and have a discussion that they've heard, most of the things that I want them to be considering before we start talking about it in person. I find that's helpful because people, can watch it on their own time, either before the visit or during that testing portion, and just start to think things over and not have the pressure of me talking to them. I get a little bit of white coat syndrome myself, so when you go see a doctor, all your questions and smartness goes out the window and you're like, whatever you say, doc, but I like people, and especially, with the decisions that they're making for us, to get exactly what they want, because there's so many good IOL choices. And there's so many choices, like we talked about, dozens and dozens of models of cataract surgery or cataract lens. And then within that, hundreds of, different types of powers. And, we can even get into adjustability, non-adjustability, trifocality, all these terms, are brand new to them. Even though we talk about them all day, every day, it's important for us to, for me to remind myself that we need to make this accessible because everyone needs to understand this.
Yeah, definitely. So with the point in the conversation with the patient where you are bringing up different intraocular lenses, is there a simple way that you break it down between the different types, or how do you approach that?
Yeah. So I try to kind of group it into 3 categories. And like I said, the analogy I find most helpful is glasses, right? So it depends on if the patient grew up wearing glasses or if they started wearing glasses, in their 40s and 50s, just reading glasses. Kind of just depends on their history, right? So that is number 1, is just figuring that out. And that can be from looking at their chart, because our technicians have put that in, or it can just be talking with them. When did you start wearing glasses? What's your preference for wearing glasses? But just back up for a second. We have glasses that are made for reading only, and we have glasses that are distance only, and then we have glasses that are bifocals, or, progressives, no line bifocals. And so then I make that comparison for IOLs. The one that insurance covers, and this goes for every insurance, commercial, Medicare, there's not any differences in terms of who covers what lens, right? They cover a monofocal lens. So that's the one focus point lens. And that lens helps you see far away without glasses. But it doesn't, I'm making a point to say, it doesn't correct astigmatism. So we talked about that in previous podcasts. But astigmatism is an irregular shape of the cornea that we can correct, again, with glasses. And similarly, we can correct that with a lens inside the eye, an IOL, with cataract surgery. So again, I always try to bring things back to glasses. But as you talked about, with the insurance covered lens, the monofocal lens, you can expect to wear either reading glasses or distance glasses to see your very best. And if you have enough astigmatism that you need glasses before surgery, you're still going to need that level of astigmatism correction after surgery, unless you have that addressed with a lens at the time of surgery. Does that make sense kind of from a logical standpoint? Like if I present it that way to people, is that getting the message across, you think?
Yeah, definitely. I think it does get the message across, and it makes a lot of sense. And like you said, even just breaking down the term monofocal lens, like you said, mono being like one, you're having one focus point. And going back to what you said about a healthy 20-year-old patient who has the ability of his or her natural lens to change shape, that has multiple, areas or focus points that the eye can focus on. And so you're now in a totally different scenario here with these monofocal lenses, where you're getting one optimal point where vision's going to be its greatest, and then there is a drop off when you are going into a different focus point. So that's very important for patients to grasp and understand. And using that analogy to their glasses, where, okay, if we're doing distance glasses, what that's like. You know what it's like to put on that pair of glasses and see really well at distance. And then you also know what it's like then to not see well up close, presumably. So that type of same scenario is going to exist even after we remove your cataract and put in this monofocal lens in your eye. And then, like you said, if you have astigmatism that was not addressed, then once again, yes, we need to address that too with glasses for your best possible vision. We need to address that astigmatism as well. And so, like you said, you hit the nail on the head. Since insurance, these commercial insurances are only covering a monofocal lens, they're not covering astigmatism. There are very many patients that have astigmatism that are kind of missing in this group and cannot have their vision completely or totally addressed with just a monofocal lens.
Yeah, I think you nailed that. And what I'd say kind of somewhat jokingly again to just lighten the mood, because, you know, it is nice that we're just talking about ways to really optimize vision. But I say nobody chose to be born with a bunch of astigmatism. You know, nobody chose to have a ton of astigmatism and need glasses. But the nice thing is that we can address that, you know, with IOLs now. We can address that with, as we talked previously about, you know, glasses, contact lenses, laser vision correction, all these things. So, you know, I feel bad. And as somebody that had a lot of astigmatism that was corrected with LASIK, you know, I get what it's like to have that blur from astigmatism. So I feel bad that certain people, we can't get them the outcome they want with a simple monofocal lens. You know, I say your neighbor down the street might have gotten perfect vision with a monofocal lens, just what they're looking for. But you wear glasses, you know, for distance. And we can expect that with a monofocal lens, you'll still need that because of your astigmatism. Nobody chose that. You know, your neighbor didn't, you know, somehow choose to have no astigmatism, and you didn't choose to have a whole bunch. But the truth of the matter is that in order to correct it to see well far away without glasses, there's a cost to it, just because insurance doesn't cover that lens cost. So I wish we could do it all for, you know, insurance coverage. Everybody could get great distance vision without paying extra. But some people just have more astigmatism than others, and nobody chose that. It's just luck of the draw.
Yeah. And then I guess if you had a patient who did want to have their astigmatism addressed, then those lenses are also available for them, intraocular lenses. And those are called the toric lenses. And so they, once again, just underscoring the point, many different manufacturers will make a toric intraocular lens. And they also come in many different powers, because once again, we are still addressing that first component, the nearsighted, farsighted component, and then we're addressing the astigmatism. So for those patients, do you talk to them about some special, unique attributes of toric lenses?
Yeah. So, I mean, what's really cool, and I think you brought this up on a previous podcast, and I've already implemented this in talking with people, is the number of things that we can do with cataract surgery or with lens-based surgery, which is incredible. So let's talk about somebody who, you know, has a cataract, so it's impacting their vision significantly, and they're very nearsighted, and they have astigmatism, right? And they need bifocals to see up close. That's a whole lot of things, and we can address each of those things with cataract surgery and with certain lenses. So that's amazing. So that's we can address nearsightedness. That's one. We can address astigmatism. That's two. We can address the cataract. That's three. And we can address the depth of focus or the depth of field. So up close and needing bifocals. That's four things you can do with one surgery. And it's remarkable. It's such a testament to how good IOLs have become, how efficient and proficient cataract surgery has become. So I stole that right from you. I love it.
Oh, no. I think you said it beautifully, but I think it's amazing when you think about the fact that what do you tell patients the average length of the surgery is going to be? I usually say 10 minutes, just as a generic average time.
Yeah. I say 10 minutes with Dr. Koushik and anywhere between 15 and 20 with me. Yeah. I usually say right about 10 minutes. That's a good rule of thumb. Yeah. It usually takes us, you know, if we looking at our cases, timing them and whatnot, there's variation based on the type of cataract and, you know, if someone dilates well versus doesn't, you know, but I could see anywhere between, you know, 7 and 15 minutes. And so 10 is a great average. Yeah.
Yeah, exactly. So in 10 minutes, you're able to completely address the four things that you just mentioned, which I think is just a modern marvel of medicine. So I think we're all incredibly lucky to be living in this age where we have that available to us. And then
I totally agree. Just to jump in for one sec, because not to gloss over it, but not only can you do it in about 10 minutes, but the recovery is very quick as
Yep.
well. The downtime is very quick. It's not a painful procedure. You're seeing immediately, right? You just have a clear shield protecting the eye, and
Yep.
you can do it on an outpatient basis. So not only are we addressing those things, but efficiently, safely, hopefully comfortably for most people. One of the things I love to do is ask people what they want to listen to, and they can put
Yeah.
whatever they want on they're the DJ when they're in the OR. So, yep.
Is there any kind of music that you would not want played in your?
I'm gonna say no because I've had all of it played.
Yeah.
It's whatever the patient wants, because it really is about
Yep.
making them comfortable.
True.
What we can do surgically is so much easier if people are comfortable, and that's part of our
Yes.
anesthesia. But it's also part of just talking people through it and having them, jam out the music. The one thing we don't like is if you bob your head with the music. Don't do that. So just nice and still. Just say, "I enjoyed this song" in a nice monotone.
Yeah, exactly. Express no emotion whatsoever.
Yeah. You can bob your head after. We can give a high five after. But it is important to be still, and we help out with that. Of course, we coach you through that as well.
Definitely. But I guess going back to IOLs, what are multifocal IOLs? Because I've heard a lot about that, and I think a lot of patients, they come in and they ask. They might not necessarily use the term multifocal IOL, but they do say that their friend or their relative was able to get a lens that does help them see at distance, intermediate, and up close. And how do you kind of navigate that patient conversation?
Yeah, absolutely. And going back to what we talked about before, there's dozens of types of IOLs, right? Over 50 types of models of IOLs, and then all those different powers. So going back to the patient that we were talking about that was in, about 70 years old coming in for cataract surgery, the number of IOLs available starts to get whittled down by their past medical history, by, what their ocular history is. If we have evidence of macular degeneration or glaucoma, they might not be suitable for every type of IOL. So that's our job as eye surgeons and eye doctors, is to say, this is the type of lens or this class of lens I think, will give you a great outcome. This other type of lens that might work for your neighbor, might not be the right lens for you. And some people are rightfully a bit disappointed about that. But I think they also understand, and I would understand if somebody's got my best interest at heart, that they're trying to get me the best possible vision. For our med students and residents and fellows out there, when we start talking about lens choices, we can't give every lens to every patient. Our eyes aren't all made the same, so we can't all have the same model of lens. And that's what I tell patients as well. If there was one perfect model of lens, I would do that for every single person. But there's not, and we have to customize it for each person. So that's kind of my spiel about different types of IOLs. And then I'll go into, if somebody has a multifocal IOL or knows somebody that's had a multifocal IOL, like their neighbor down the street, I'll say, like we were talking about with a monofocal IOL that has one focus point, a multifocal IOL, multi has multiple focus points. So that can be distance, kind of intermediate or computer distance, and reading or phone distance. So those are kind of the three distances that we talk about for a multifocal, or one of my favorites type of multifocal is a trifocal IOL. And so the goal of that is to get you as much glasses independence as we can get you, so that you're not needing your glasses to see up close. You don't need reading glasses for your phone, and you don't need glasses to, see your golf ball 200 yards away, or if you're Dr. Koushik 400 yards away, either way. But that's kind of the goal of, multifocal IOLs. Now, I do tell people there's no cheating physics. So the amount of light entering the eye is the same, no matter who you are. So if you take a monofocal lens and you take all that light and focus it at one point, you're going to have the best optical clarity. You're going to have the best quality of vision because you're taking 100% of the light and focusing it at one point. Now, it's not, perfect up close because you're not focusing it for up close. So you put on reading glasses and now you have 100% of light focused up close. But you put your reading glasses on like far away and you realize 100% of the light isn't focused for far away. So you're really, with a monofocal lens, you're changing that focus point with putting glasses on for reading or taking them off for distance. But again, the quality of the vision is the very best because you're taking 100% of the light and focusing it at one point. And what a multifocal does is take that 100% of light and split it. And I tell people generally, this is about ballpark of what happens is you take a third of it for distance, a third for intermediate, a third for up close. So that doesn't mean that your vision is 33% as good at distance, just the way that our eye works. There's so much light entering the eye that you'll still see very well for distance, but it's not as good as you would see if it was 100% for distance, right? So I tell people at distance, you might notice a little bit, of diminishing of that distance vision. Although people that have significant cataracts, they are going to see an improvement no matter what, right? But intermediate and up close should be much better than they are right now, uncorrected. It should be much better and less reliant on reading glasses, as long as we hit our mark. And we can talk about that in just a little bit about how we do those calculations and talk about on the resident and fellow level, the best way to do that. But assuming that we get the patient the outcome that we desire, they'll be much less reliant intermediate and up close. But again, that trifocal splits light. So there's no cheating physics. You can't have more than that 100% of light entering the eye. Is that about what you do, Dr. Koushik?
Yeah, I think you hit the nail on the head, and that's fantastic. I've heard it described from mentors, and I think you have too, as you have a photon budget. So you just have a certain amount, and this is fixed for everybody, that's of light coming in, and then how you choose to spend that light or spend your budget is up to you, and we're just helping you navigate that process as the surgeon, and helping make sure you're well informed about expectations for the multifocal lens versus a monofocal lens. But as long as you're understanding of that and you have an idea of what you're going to get, I think any option is truly a great option. It's just making sure you're well informed. So yeah, having that photon budget in mind and explaining it the way that you did, I think is great.
Yeah. At the same time that I say there's no perfect lens, I also say there's no bad lens. You can't cheap out on a lens. There's no bad lens that I would implant into somebody's eye. So, you're going to have a great lens. It's just how much glasses independence are we talking about?
Exactly. Yeah. And I think that's another great point that you mentioned, is how much glasses independence are we talking about? I don't typically ever say that you will have 100% spectacle independence. I feel like that is a high bar to promise and to hit. And I think, you will have patients that for them and their lifestyle, they are 100% spectacle independent. And it just so works out really well for that patient because of the things that they're doing fit in nicely into the ranges that the intraocular lens can service. But other people, the same lens, the same essential eye anatomy, they do need to use their glasses maybe 5% of the time or 10% of the time. And I don't think that is in any way a failing of the IOL or a failing of the patient. I just think that just goes to show that while we are making great strides in lens technology, it's not as perfect as that beautiful crystalline lens you had when you were 20 years old. Yeah.
Yep. That's exactly right. Exactly right. That's kind of the way I like to phrase it, is how much glasses independence we're able to achieve. And again, even though we can get a lot of patients 100% free of glasses, it's not practical to promise that to every single person. Even though I tell people that's my goal, like I really want that. Yeah. It's not something that any surgeon can do 100% of the time, even though we make every effort to do it, and if post-operatively we don't get the outcome that we want, there's still things that we can do to address that, whether it's addressing residual astigmatism, refractive power. Basically when I talk to patients, I say it's not over once cataract surgery is done. We want to get it right the first time, but there's still opportunities to get the vision that you want if we're not quite there yet. Another thing that our listeners brought up, we're getting some feedback finally from listeners, Sud. It's pretty exciting. Is they were confused by what diopters were. So I know we kind of glossed over diopters. That's a unit of measurement that's kind of our main unit of measurement in ophthalmology. And I was told by one of our engineering colleagues that it was very helpful to say it's a measure with the units 1 over distance, 1 over meters. And I was like, that's perfect. That'll clarify it for like 4 people that are engineers that listen. But for everybody else, diopters are really that number that you see on your glasses prescription. That's diopters. Yep. So it's a unit of measurement of glasses, of lenses, of IOLs. It's a measurement of how much power, how much focusing power a lens has. Is that a good way to put it, Sud?
Yeah, I think that's a great way to put it. I'm just laughing too at the fact that since we're doing meters in relation to diopters, and we're in the United States of America, we're
Yeah,
already starting at a disadvantage. I think
that's a good point.
having
Most of
to
our listeners are in Europe
yeah
though, so it works out
yeah
nicely. Yeah.
they're up to speed. They're ready to roll. But
Yeah.
I
One
wish
over
I mean
3.2 feet or whatever the conversion is. Yeah.
yeah. Can you imagine how complicated it would be if we had to use the imperial system and we were
Oh my
using feet
gosh.
and inches oh man, it'd be tough.
Thank goodness we didn't do that. Thank goodness.
Yeah,
Yeah.
exactly. But yeah,
Yeah.
no, I think that's great. Yeah, it's just a standard unit of measurement that we use. And another way also to think about it is the higher the number of diopters, uh, whether that's plus or minus, you can
Mhm.
just imagine that higher number is requiring more focusing. So obviously, it's your vision is starting off, I think, a little bit more impaired the higher that number is. So that's just like, I think, a very basic way to think about it.
100%. And where some people might have come across this, if they don't look at their glasses prescription much or don't have an idea of that, is also just going to, the Dollar General and picking up some readers and seeing that there's plus ones, there's plus twos, there's plus 2.50 or 250, there's plus 3.0. Those are diopter measurements, right? And so the higher those go, the stronger the prescription is, the stronger the glasses are. And I also use that to talk about focal length. So like a plus 3 reading glasses, you hold closer than you do a plus 1. A plus 1 you might wear for, computer distance because one diopter is focused at 1 meter, right? So that's kind of where I start to talk to people, especially that are engineers. They always bring that up. They really do.
Yeah.
The thing that I found interesting that wasn't on my radar so much was we use the same unit for cylinder or for astigmatism as we do for nearsightedness and farsightedness. So diopters are the same whether it's spherical or cylindrical, and cylindrical just means astigmatism correcting.
Yeah, no, that's a great point. And I don't know about you, I kind of do a cop out with the readers, because I usually like to tell patients, just go try on a plus 1 or a plus 2 or a plus 3, and then grab a book or a magazine and hold it where you would like to hold it, wherever that may be.
Yep.
And find out which one works the best for you. Because even though I do feel like I am doing a cop out there because I'm not measuring their distance and I'm not coming up with a number for them, I feel like it's just easier for the patient if they're just more comfortable with a certain distance, and then they can get to actually see what that does for that distance. It's a very
100%.
low cost method. Yeah.
I do the exact same thing. And
Okay.
another reason,
like
it's not a cop out. It's not a
Okay.
cop out at all. I think another reason to do it is when you're in the doctor's office, when you're in our office and you're wearing, that phoropter, that's the name that we have for that machine that we say one or two. If you're wearing that and we flip something down, yes, we can kind of test your near vision, but it's not in real world scenario. It's not you wearing glasses where you like them on your nose, where you like them on your face, where you like to hold things, right? All that, like you said, in the real world, when you're trying that on at the drugstore, that's the way to do it. So not a cop out. That's the way to do it.
Okay. I feel better knowing that I'm in good company with you. And that you do
have you
this.
ever had, hey, I feel like I'm picking on engineers for a second here, but a lot of people that I love in my life are engineers. So I feel like it's okay.
Yeah.
But have you ever had somebody come in and be like, I want to see well at, 15 inches. That's where I hold things. Or like my computer is 1.3 meters away. And that's where, like they have it actually measured out.
Exactly. Yeah, I know.
Yeah.
I always feel like that's intense, but I get it. I mean, they're detail oriented, and I respect that. So
you want them to be. You want them to be. So for those patients, let's say, getting back to cataract surgery and lens choices, IOLs that are available that have that level of predictability and precision, right? So we talked about you come in, you get measurements, your eye is a certain length, it has a certain power to it. And just to digress again, one more second here, I'm just for a wow moment here, what we can do with LASIK and EVO and SMILE and PRK, they're incredible technologies. Our range is, let's say, minus 20 diopters, right, for EVO, minus 20 diopters, 4 diopters of cylinder, and then up to, talking about now LASIK and PRK, what would you say, 4 diopters of
Yeah.
hyperopia plus 4.
Mhm.
And
Yeah.
then again, astigmatism, 3, 4 plus
Yeah.
ish diopters. With cataract surgery or lens-based surgery, it's the most powerful refractive procedure that we have, right? So
Yeah.
somebody who is a minus 30, we can correct that. And somebody
Yeah.
who is a plus 15, we can correct that. So it's just unbelievable, what we're
Yeah.
able to do with the lens-based surgeries that we do. So the
Yeah.
technology and the IOLs are incredible. That's just the range of powers. And now we're talking about how do we do multifocality in addition to that? How do we do multifocality in addition to astigmatism correction?
Mhm.
So it's incredible. But anyway, that digression, going back to our patient, we have
Yeah.
measurements of your eye. We have measurements of, what lens power we need to predict, and that is based on some great research over decades and decades, of very smart ophthalmologists and mathematicians,
Mhm.
physicists, all sorts of people, engineers for sure were involved in the making of
Yeah.
this IOL formula. Yeah. Um, but getting that predictive power to be right now in 2024 about, what would you say, 90%, 9 out of 10 people just kind of
Mhm.
hitting bullseye. And that leaves
Yeah.
about 10% of people, just because of the limitations of, kind of extreme uh, measurements on the patient side. So we're really good at hitting the outcome for eyes that have never had surgery and
Mhm.
eyes that are very average. Very
Yeah.
good at that. But ones that lie on the extreme, whether it's very, very far-sighted, so they need a high plus power lens, or they've had previous surgery,
Mhm.
specifically LASIK, PRK, or they've had retina surgeries, like you talked about, a buckle or some type of silicone oil or something. That's harder to
Mhm.
predict.
Yeah.
But let's say on average, 100 people come in, about 8 to 10 of those patients, we might not hit the bullseye for the power that we're looking for.
Mhm.
So that's just a limitation of our formulas. So that's when we talk about what are ways that we can change that outcome post-operatively. Like you said, glasses, contacts, always a great option.
Mhm.
Um, but there's also lens choices that we can start to, implement with patients over the last few years that are
Yeah.
incredible, that can address that as well. So you want to take a second to talk about what that technology is like, and kind of
Yeah.
uh, how you implement it in your practice.
Yeah, definitely. So, what Sam is mentioning is a type of intraocular lens, and that's called a light adjustable lens. And so, what this allows you to do, it allows the surgeon to pick a power of this lens to get you to where you want to be after surgery. And I would say, in many cases, you get very, very close to where you want to be. And then you're essentially fine tuning that last, maybe let's call it 10%, where you're just trying to dial in that last 10% to get the vision to be exactly what you want. You can actually do that in the clinic setting, in uh, the slit lamp. We use a special light delivery device. And this can just take anywhere from maybe 30 seconds to a couple minutes to actually tweak that prescription to get it to where you want it to be. And we have the ability to do that um, multiple times so that even then, let's say we don't get it on the first treatment, this I call it a light treatment, on the first light treatment, we can always repeat that light treatment again to see if we can get you closer. And so this technology, I think, is wonderful. It definitely, and Sam can jump in and let us know how he uses it or what patients he uses it for. But oftentimes, I'll find myself using this on patients who have had refractive surgery in the past, like LASIK, SMILE, or PRK, and where the estimations that Sam was talking about, the calculations that we use and the formulas that we use, even though they are really, really excellent formulas, they just might uh, miss the mark just slightly on these patients who have already had surgery to their eyes. And so this lens, the light adjustable lens, gives you the opportunity to then go back and tweak that lens and fine tune it. So I think it's a really tremendous technology that a lot of patients are getting these days to help their confidence and surgeon confidence at delivering the type of vision that the patient wants after surgery.
That's a perfect summary of it. That's exactly right.
Yeah.
And what it does is it opens the door to so many things, right? It opens the door to very reliably hitting that bullseye every time, right? Even if we don't hit it with the exact calculation of the power that we initially thought, we can tweak it to that.
Mm-hmm.
It also opens up the door to testing out, the patient is in charge of what they want post-operatively. They get to test drive their vision. So we can start talking about blended vision or monovision or mini monovision. All these terms are ways of tweaking the lens so that you are, testing out if you can get more up close vision, get more near vision without sacrificing your quality of distance vision as well. So it's not a true multifocal lens, the light adjustable lens, and now there's the LAL plus or light adjustable lens plus. But again, a lot of people, for me, patients coming in, their goal is to be as independent from glasses as they can. And this is a great part of our, tool belt of getting them that. So it gets us an amazing, I tell them it's really hitting the bullseye almost every single time. It doesn't have some of the drawbacks that patients will sometimes talk about multifocals having. So we talked about multifocal lenses, multifocal IOLs that have rings, rings inside them that focus the light at that 3 targets, distance, intermediate, and up close. And it's a fantastic lens. I've implanted it for probably hundreds of people now that are very happy with it, and they love it. But a lot of them can tell me, I see those rings. I see the rings around point sources of light. It doesn't bother me, but I can notice that, and it's different than it was before. Now, most people, especially after cataracts or after they have cataracts, their vision's already so much better with the surgery that they don't mind that. Where I've found patients are a little bit more discerning is if they, we're coming in for a clear lens exchange, a refractive lens exchange. And I talk to them a bit more about that. I'm like, your distance vision right now is very good. And whether you wear glasses or not, it's still quite good. You don't have cataracts that are significant yet. So you might notice those rings a bit more than somebody who has really significant cataracts and already has glare and halos. Going back to the light adjustable lens, there's none of those rings, right? But it doesn't give you the up close, very fine print in the same way that multifocals do. We can adjust it post-operatively to test drive that and see if you like more near vision, but it does take away oftentimes slightly from your distance vision. So that for that reason, we'll oftentimes do it in your non-dominant eye. And most people I've found have been very, very accommodating and love that. They get to test drive it with a contact lens if they want to beforehand, or we can make small enough adjustments that we can get them seeing the way that they want up close without sacrificing much in terms of distance. I mean, I've had patients getting down to the nitty gritty here that are, 20/20 J1 in the same eye, not binocular, but 20/20 J1 with a light adjustable lens. So, we don't never want to overpromise. We want to give realistic expectations, but at the same time, the technology is becoming so strong and so dependable that we can oftentimes deliver exactly what they want, in a very, very reliable way.
Yeah, I mean, I think it's a fantastic lens, and the opportunity to adjust after the fact. I mean, it's the only lens that gives you that option. And I mentioned that I do like to use it for patients who have had refractive surgery in the past, but just so people who are listening aren't confused, you can use it in any patient's eyes. Really, there is not a stipulation that you need to have had LASIK in the past to have this lens. That's not the case. So you can use it in patients who have never had surgery on their eyes, which is great, and give you that level of customizability.
That's right. For the last minute or two, or whatever, 5 minutes, however long this lasts, but you want to just talk about either some patient cases that you've thought about when it comes to IOLs and multifocals, monofocals, torics, or want to talk about from kind of like a med student, resident, fellow level. What lenses in 2024 we have had great experiences with, what lenses have delivered great outcomes for patients and dependably. I know we've talked about light adjustable lens for a little bit here, and LAL plus, which is trying to give a bit more of near as well. But other certain models of lenses or patient cases, whatever, kind of open the floor up to a bit more for the general population out there listening, please stay tuned, keep listening, but it may get a little bit technical for a second here, but I'll bet most people can keep up with it, I'm sure.
Yeah. I mean, I think another lens that we can definitely talk about that I've used with good results is the IC8 Apthera lens. And so we've talked about it previously, where patients come in who have had, let's say, refractive keratotomy in the past, or RK, or maybe they've had a condition called keratoconus, and their corneas are now, let's just say, shaped a little bit out of the ordinary. And some of the light that enters through this cornea is causing suboptimal vision. And so using a lens like the IC8 lens, it achieves its effect through a pinhole, and it is blocking out some of these peripheral light rays, and it's limiting those peripheral light rays from actually hitting the retina, and only allowing those light rays that are actually coming through the center of the optic to actually reach the retina. And that actually reduces a lot of these aberrations in these corneas. And patients report really good vision with this IC8 lens. So I've used that in patients who have had RK. I've used that in patients who have had keratoconus and had great results. So I think that's another great lens technology out there. Once again, choosing the right patient for the lens is very important. And some other things I'll mention, since we are talking about that lens, is centration is so important with that lens. So you really want to make sure that there's no issues with the zonules, and that it would actually maintain its centration really well. Once again, since you are blocking out light, you want to educate the patient that they will experience a dimming type effect, and you want to do a good dilated exam, like we talked about earlier in this episode. You want to look at the retina very clearly, because you want to make sure there's no other issues that would make it hard or challenging for your vitreoretinal colleague that might need to operate on this patient, and not make their job harder having to deal with a lens that's blocking out so much light, and also blocking their view. So these are other things that are important, making sure also the surface of the eye or the cornea is also clear from dry eye disease and things like that. Anything to set you up for success with this lens, you want to address those things as well. So that's another great lens I think I like to use and have used with success.
Yeah, I totally agree. I had actually that brought up an interesting story from last year. So last year we had an OR day where we were doing cataract surgery. We were doing EVO ICL, so on subsequent patients, we first had an IC8 or Apthera, which has that pinhole optic. And then afterwards, we had a patient we did EVO for. And so the OR staff in the room, much smarter people than I am, apparently, because they were like, hey, we can do these procedures, but is there like an EVO lens that has, a pinhole aperture? Is that possible, so that we can get people, that have keratoconus that already do well with EVO? Could we get them seeing even better? Or could we do it so that, we're aiming for a bit of monovision and we can get people glasses independence? Can we get like an EVO that has the Apthera built in to get that pinhole aperture? And I was like, brilliant.
Yeah, exactly. Yeah, I mean, I think that's a fantastic idea. It's really cool.
Right.
And you'll be surprised in those kind of scenarios where you're like, why didn't I think of this sooner?
That's a great idea.
Yeah.
But somehow that's just
Actually,
how like ideas are born, is just like having technology, having people thinking outside the box, doing, all sorts of different procedures all on the same day. So
yeah, I do think, and I might be wrong on this, so I'll have to fact check myself as I search this, but I believe in Europe there is a IOL you can put in that does not have a power, but is essentially creating a pinhole that you can combine or piggyback with a lens of your choice. Any other kind of lenses that you're using recently that we might not have touched on?
yeah, I mean, I'd say just to name drop, because I just use this lens a lot, PanOptix. I use the PanOptix a lot because it's a trifocal that I've had great outcomes with. And that's not to say there aren't other great trifocal or extended depth of focus lenses. But that is just one that I've had great outcomes with. And I tend to stick with it because it's so good. I don't routinely use an extended depth of focus lens, or what we call an EDOF lens. I don't use, any of those major ones that are out there. I kind of think of the light adjustable lens as that, with the benefit of adjustability. So anyway, this is getting technical, but I think it's worth people hearing, and I just love talking about it with you. So it's fun to just talk about. Yeah.
No, definitely. Yeah, I like the PanOptix lens as well. I have not personally implanted the Odyssey lens, but I have heard, people having great success with that lens as well. So something just to mention for residents and fellows and attendings out there. I think there's a lot of people talking about the Odyssey lens and how they've used it and what patients they've used it for as a great option.
Absolutely. Yeah. I mean, anytime you have an eye surgeon or an eye doc that gets a lens into their eye, because they believe so strongly in it, it's a good sign, So we had a doc in our area that had Odyssey in both eyes and loves it. So that's always a great sign. I mean, there's probably every type of lens has probably been put in an eye doc at some point, because like we talked about, there's no bad lens. There's just, pros and cons and kind of what you're looking for in terms of glasses independence and what small trade-offs, but real trade-offs that you're willing to make for that. And same thing goes for you, with Evo, trust it enough that you put it in your eye. So
exactly. Yeah. I think you hit the nail on the head. There's really not any bad technology out right now. It's just getting people the right technology for their eyes and their expectations. So that's the beauty of ophthalmology and the art of medicine, I guess.
Yep. And last thing to touch on, and we can cut this if we want to, but just talking about like kind of cost. So we talked about out-of-pocket cost being a thing with kind of astigmatism correcting lenses, multifocal lenses, all these lenses that insurance doesn't cover have a cost associated with them. And that cost is the cost of, it's important to remind ourselves, it's the cost of like developing this technology. It's the cost of, getting people more glasses independence. It's the cost of getting FDA trials approved, of going through all that. I mean, that takes years of rigorous testing and literally millions of dollars to develop those lenses. So that's kind of what gets baked into the cost of us buying those lenses, and then, doing the right calculations and taking care of patients the right way and putting that lens in if it's indicated, right? So that's kind of the background for why there's a cost for those lenses. But roughly, what are we talking about when it comes to prices in 2024? I mean, you can break it down to however you want, like one eye, both eyes, month by month basis. I tell patients, I'll go ahead and tell you what I tell them. Based on what we're doing now in 2024 for, let's say, there's kind of different ranges or different price levels. So if we're talking just toric or astigmatism correcting lenses, we do care credit, which is a 2-year financing that I, have a hard time arguing against, because it's 0% interest loan that you repay. So if people want to pay in a lump sum up front, I totally understand that too. But breaking it into monthly payments to me makes a lot of sense for most people. So I tell them, it's somewhere around $100 a month for a toric lens. And then you pay that through care credit. And that's kind of comparable to thinking about the rest of your life needing to pay for glasses over and over again. So that's one way I talk about it. And then, more about $200 a month for, astigmatism correcting lens plus a multifocal lens. So kind of that combo. But then talking about it just lump sum wise, a patient can expect maybe somewhere between $2,000 and $5,000 probably. Is that about accurate for what we're talking about for these lenses?
I say the same thing about that range and per eye. We are talking about per eye. I like also what you said about kind of making that analogy for the rest of their life, because let's say a patient comes in and they don't have cataracts, and we're now talking about a refractive lens exchange or a clear lens exchange. And let's say that patient's 50 years old. I'm trying to put it into perspective for them, where we're now talking about, let's say, the next 35 years on average. And I think that helps put things into a lot of perspective, because if we're talking about a lump sum or a single cost payment per eye, you might hear, $5,000 as a tremendous amount of money. And I'm not here to say that that's not a lot of money. I definitely think it's a decent amount of money. But I think when you then start thinking about, okay, over the next 35 years of my life, this is what that money is going towards. I think that's a much, a different scenario to play into your head and understand what you're really getting. So I think that putting that into perspective really helps. But as far as the actual numbers that you referenced, I think I'm in agreement. And breaking it down monthly actually makes a lot of sense, especially if you are doing something like a 0% um, financing option. I mean, 0% is fantastic. You can't beat it. So
You can't.
that's,
By
yeah,
the time you're done paying it off, it's, you're paying less than you originally agreed to pay because of inflation.
exactly.
So
Exactly.
especially the
Yeah.
way it is right now, 5-6%. So you
Yeah.
can't get any other loan for, that amount for 0%. You can't get that. If you're buying a house right
Yeah.
now, it's like 7%. So
Exactly. I mean, you
yeah,
look at any cars. I mean, there are very few car manufacturers offering a 0% deal right now
yeah,
for financing. So
yeah.
yeah.
I also like to make a joke, that kind of makes light of, or, kind of brings into why I say month to month for the cost of this. It's like if you were looking for an apartment or somebody's renting, renting a house or renting an apartment, you wouldn't be looking and saying, I'm looking for a place and I'm in a certain budget range. You wouldn't say I'm in like a $24,000 range. You'd say like, oh, I'm
Mhm.
looking at $2,000 a month. Like that's how we break down
Yeah.
bigger purchases to make them, more approachable for all of us. I
Mhm.
wouldn't say it's $50,000 a year. I'd say it's $2,000 or $3,000 a month for rent.
Yeah. That's a great point. Yeah. It's amazing how much relativity changes things, right? If you're
Yeah.
actually putting things relative to other things that you're using, like rent or whatever, cars or houses and things like that. So I think that helps definitely.
Yeah. Well, I could talk about this forever because IOLs are
Yeah.
awesome. We honestly could, we have a lot more to cover. We'll do it on future
Yes.
episodes. But I think that'll do it for this episode of Now I Know. What do you think?
Yeah, I agree. I think we hit a lot of big topics today, and hopefully we've clarified that there are a lot of different intraocular lenses, but your surgeon and you are working together to pick the right one for your eyes.
Yep. That's a great summary. All right. Till next time, guys. Thanks. This was Now I Know.